There'll be a chance for questions later, but we're going to get our next speakers on now because we're going to talk about, as I say, reconfiguration, and I'd like to invite our next speakers onto the stage. Reconfiguration, the idea of closing anything, redesigning something, it's what's become apparent is you're not going to, it's not going to happen unless you get all sides involved, not just the managers, and we're going to hear from Stephen Dalton in a minute, but also the patients, the clinicians, and the politicians. So we've got a representative of each. Let me introduce, first of all, for patients, Jeremy Taylor, who's Chief Executive of National Voices. On Jeremy's right, Dr. Patrick Cadigan, who's from the Royal College of Physicians and on the Future Hospital Commission. But first, though, let's hear from the manager. Stephen Dalton is Chief Executive of the Mental Health Network.
Well, thank you very much. I'll be very happy to say that I agree with lots of what Andy said, and I think some of it is a very bold vision, and that's great. I've worked in the NHS for 37 years. About half of that time I worked as a clinician, and about half of that time I've worked as a manager, principally as a chief executive for 17 years. So I've worked under and for many secretaries of state for health, and you know, they've actually all very often agreed with much of what Andy has said, and the transformational change that needs to take place in our acute sector, many of them for many years have talked about it. I think the message I've heard over the last 3 days in this conference is what we need to do is do it. And I think what we need is a Secretary of State who's going to actually have the courage to make some of the change. I've been asked to just reflect on what happened in mental health, which is one of those rare beasts in the NHS where there was transformational change. And it didn't happen quickly. It's happened over my lifetime of my career. And so it's not a quick fix, and it's far from being fixed. But that transformational change in mental health did happen, and I think it provides us with some hope. And one of the reasons why I think it happened was that one of the curious things in my career, both as a clinician and as a manager and as a chief executive, working in mental health, was that when I was a clinician, I knew what the strategy was. And when I was a chief executive, I knew what the strategy was. And I think, I wonder how many of our staff know what the plan is. And I think that's something which we need to go back to our organisations and ask ourselves, because that's what made the transformational change work, in my opinion, because it was so obvious what we were trying to do, and we were getting on and doing it. We weren't just talking about it for decades. We actually got on and did it. And why did we do it? Well, I think we did it because we found that thing which is reflected in the report, and other colleagues are going to talk about this one that was published, that Mike referred to on the first day, this changing care, improving quality. And it was about getting consensus. But that consensus was a consensus across a clinical and political axis. It wasn't true that it was a consensus with the public, because many of you might remember care in the community. Care in the community actually became, at one time, quite a pejorative phrase, and certainly it was something that the media sneered at and called a failed experiment. But that effectively was the plan that we were working to, and it was the one that we believed in. So it's been difficult, and we did difficult things. You know, there's so many similar conversations that go on now about the acute hospital sector that went on about large institutions that were called mental health hospitals. Moving what most of us experienced, which was 1,500 bedded hospitals, to a population being served by somewhere between 5 to 10% of those beds, and the rest of care being delivered in a fundamentally different way, was what happened in mental health services. It didn't happen quickly, but the big shift happened when you got the clinical and political consensus. The truth is that at times, as a chief executive, I lost my faith in the strategy and couldn't imagine how you could actually move that quickly and to so few beds. But we did it. We did do it. And I think the report, really, in terms of its recommendations, can be summed up as asking leaders to very publicly sign up and display respect, ambition, and courage. I think that's what we need from leaders. And I want to focus on one particular area, which I think also contributed in a massive way to that transformational change in mental health. And because we've got Andy here, I would say this, wouldn't I? But it was about political courage. One of the recommendations says we need to establish political consensus on clinically driven change. We absolutely need to do that. But the other piece of information that came out of this conference was, in a recent survey by the Confederation, 67% of leaders believed one of the greatest barriers to successful reconfiguration was political resistance. And we've got to get over that, and we've got to work with whoever the next Secretary of State is, if it's Andy or whoever it is. And if we're going to tell the staff in the NHS, if our political leaders and if we are going to tell the staff that they have a duty of candour, and we all have a duty of candour, that rings hollow if politicians can fail to be honest and not courageous. So we need that duty of candour from politicians too. I'm going to end there and hand over to my colleagues.
Stephen Dalton, thank you very much. Now let's hear the patient's voice from National Voices, Jeremy Taylor.
Thank you. National Voices was very pleased to collaborate with the Confed and the Academy to do this joint report, Changing Care, Improving Quality, about reconfiguration. I don't think we would claim that our involvement in it represented the involvement of all patients, but we did provide a very important patient perspective, a health charity perspective, and the work involved the detailed input from a number of patient organisations and service users. So we're very pleased to have been part of that, and it's a good report. If you haven't read it, please do. I want to say a little bit about the case for change and a little bit about the decision-making process in making those changes. I think we've heard a very powerful case for change today from Andy, and in a way, probably the most articulate articulation of it. We've got the wrong kind of pattern of care for our current needs. The right care is not in the right place at the right time. Our hospitals are not optimal, and we don't have enough person-centred, whole-person, coordinated care based around people's homes and communities. And indeed, I think there is an opportunity to make a moral case for how that current pattern of care is so bad for some groups, particularly very frail older people, in exactly the same way as a moral case, a clinical and moral case, was made for the changes in mental health and the realization that warehousing people in institutions was wrong. I think there's a lot more we could do to make a really good case for change. But in a way, it's relatively easy to do it in general and at national level. The problem is it's much more difficult to do this locally, and the issues always play out specifically and differently, and they become political and contentious. And I think part of this is recognizing that it will always be contentious, and if you want to make change, then there will be hostility, there will be resistance. In a sense, that goes with the territory. But when looking at how to make a local case for change, I would certainly support the Lord Darcy principle, which we don't hear quite enough of these days. Quality should be the organising principle of the NHS, and it should be the organising principle of change. In practice, access and cost and quality all come together in a complicated mix, but quality for me needs to be the driving principle. In the report, there's a quote from Paul Burstow MP, who was consulted as an MP because we thought it was important to get the views of those politicians who are often cast as the villain. And his view was actually one of the things that goes wrong in reconfigurations is we ought to have an additional test to the 4 ones that Andrew Lansley put out at the start of the coalition government. And test should be, does this change in service lead to a better development of primary and community services for local people? And if it doesn't, we should question why it's happening. So I think the case for change is easy in one sense, but really difficult when you get it locally. And I think the NHS has not been good at making the case. Let's talk a bit about the decision-making process. The report deals with this in some detail. It calls for greater leadership, easy to call for, harder to do. It calls for better communication with clinicians, with staff, with patients and communities. And it calls for better collaboration. And I think the distinction between communication and collaboration for me is really pivotal, because I think the debate about how major service change should be made, I think is often couched like this. Oh God, the current pattern of services is not right, it's not safe, it's not sustainable, it's not good. We're going to have to change it, and the public won't like it, but we're going to have to try and find a way of persuading them. And actually, that's a discourse about public relations and about communication. And yes, the NHS needs to be better at communication. It needs to be better at public relations. But this is not about having better spin. It should be about collaboration. And for me, there's a fundamental distinction between how you manipulate your public into agreeing with the decision you've already made, and then going through what might be a fairly sham consultation, and actually doing what David Nicholson talked about last night, which I thought was really profound, and I hadn't heard him say this before. The patients are part of the solution. Patients and communities are part of the solution. So work with your local communities to actually work out what the case for change is, and then to work out the solutions so that they are owned by the community. That may sound idealistic. It may not be possible to remove resistance and hostility and kickback because we live in a real world, but we haven't really tried hard enough in a systematic way to change the nature of the debate from one about consultation stroke coercion to one of genuine co-production. And my final point is, and again this comes up in our report, there are different kinds of reconfiguration. There are the ones which are about getting services into the community and away from hospitals, although some people would argue the hospital is the centre of the community, so we need to be careful about language. There are other reconfigurations which are around actually you need to concentrate activity in a smaller number of places to get the expertise and the safety and the sustainability. There's a third category which you could describe as crisis-driven reconfiguration, and I think what happened in South East London and Lewisham is a classic example of the kind of reconfiguration that's driven by essentially financial considerations. It feels like the NHS is letting the local community down. It all happens very quickly. There's no proper time for engagement. That is the kind of thing that gives reconfiguration a bad name, and we need to find a better way of organising service change, which will be sometimes, inevitably, in current circumstances, driven by financial problems, because at the moment we're setting up the NHS for failure every time it makes any kind of significant change. Just finally, while Andy's here, and it's, I can't resist just coming back, your vision of whole person integrated care is incredibly powerful and seductive, but please be aware of the unintended consequences of your well-intentioned policies. We've seen that again and again in the NHS. I liked what you said about doing this in an evolutionary way, were you to be back in office. The NHS doesn't need a revolution. Again, it's bad for patients. It takes people's eye off the ball and means they can't concentrate on improving care. Please, please let voluntary organisations and other stakeholders work with you, Andy, to get your plan right so that if you are Secretary of State for Health again, we don't have another unintended reorganisation. Thank you.
Jeremy, thank you. And finally, Dr. Patrick Cadigan, who, as I say, is from the Royal College of Physicians, for the clinician's voice.
Thank you, and thank you to the Confederation for allowing me to speak on behalf of the Medical Royal Colleges. So it was on Wednesday that the Confederation, Patient Voices and the Academy jointly launched our document, Changing Care, Improving Quality, which confronts with sober realism the difficulties faced by organisations and individuals who seek to reconfigure NHS services. On the cover of the document is an image of placards held by marchers with the legend, "Save our hospitals." That's an iconic representation of the layers of loyalty, emotion, fear and suspicion that confront those who propose changes to either the location or the level of an NHS service. My favourite quote from the document likens the process of reconfiguration to fixing an engine while the motor is still running. And that's a powerful image that will be easily recognised by those managers who struggle operationally to continue to provide a service at the same time as trying to take a strategic view of its transformation. Medicine abounds in these motoring metaphors. A colleague of mine used to tell patients that they were not exactly in showroom condition. More sinisterly, an article on the BBC website on the 23rd of May asked the question, is the NHS going to blow a gasket? Now, it's that concern for the ability of the NHS to continue to deliver safe, high quality and sustainable services to patients that has fueled much of the work done by Medical Royal Colleges over the past 3 years. Reports from the Royal College of Physicians in 2010 and from the Academy recognised the risks to patients posed by reduced services out of hours, and both strongly argued for a move to a 7-day service, a solution which would have inevitable consequences in terms of reconfiguration. In September 2012, the Royal College of Physicians published its hard-hitting Hospitals on the Edge document, which collected together the evidence for the many systematic problems that physicians were facing in providing high-quality care. And the challenges of this winter have brought the service even closer to that edge. And the reports earlier this week of A&E departments failing to meet targets are clear evidence of a system with inadequate global headroom to accommodate variations in demand. So until now, there's been no clear statement of how best to go about implementing changes of the magnitude which will be needed to secure the system for patients. The RCP Future Hospital Commission is due to report in the autumn and will provide some possible solutions for the hospital sector. But it's against this background and in the shadow of Robert Francis' 2 reports that the Academy Council was keen to sponsor a joint publication setting out the case for change. I will go on to talk about some aspects of the report which are of particular relevance to clinicians, but I want to say at the outset that by far its most important message is its joint authorship. It is the message that in this matter, managers, patients and clinicians have common cause, and that we wish to work towards the same outcomes. It's the message that while we have different perspectives, different expertise, and different experiences, these can be brought together in a complementary way to deliver a vision and a programme which is powerful and persuasive. Of course, hospital and community services will need to evolve in the face of demographic change and medical advances. The clear challenge to these services is the presentation of an increasing number of older patients with multiple comorbidities, including dementia. And the absolute test of the success or failure of our healthcare system over the next 20 years, and the test we should use to evaluate any plans for reconfiguration, is how we will care for this group of patients. Rockwood, writing in Age and Aging, underlined this point, saying, if we design a system for patients with one thing wrong with them, and patients with several things wrong with them turn up, the fault is not with the users, but with the system. Now, most commentators agree that leadership from doctors and nurses and their clinical colleagues is a critical success factor in carrying through a programme of reshaping a service. And this is not surprising. Clinicians are trusted professionals with an intimate knowledge of the service that they deliver locally, and also have a wider knowledge of how care in their specialty is delivered to patients elsewhere in the UK and internationally. In addition, clinicians have the advantage of working both directly with the patient and directly with the organisational structure. They are often in contact with local and national patient groups, and they're well placed to bring their understanding of patient issues, their professional knowledge, and their professional work relationships together to act as catalysts for positive change when they are convinced of the evidence for patient benefit. And so that evidence is a vital part of building a case for change into a positive framework, a framework that can be shared frankly with a clear understanding of the pros and cons between clinicians, patient groups, commissioners and managers. The notion that clinicians are cold and dispassionate scientists who will always be persuaded by the evidence is, of course, a naive one. Loyalty to institutions is hugely valuable and laudable, but can be a barrier to change for both patients and their doctors. Clinicians whose life's work has been the building up of a service are not easily persuaded to downgrade it or to see it moved elsewhere. There can also be difficulties in the collaborative working, which is such a key recommendation of the joint report. We have to admit that clinicians can behave tribally, as members of the tribe of doctors, or even more tribally as members of the tribe of, for example, cardiologists, and all these are different from the tribe of managers. The most important factor in overcoming these barriers will be courage. Reshaping the service will require strong, courageous, and collaborative leadership from clinicians, patient groups, managers, and politicians working to a shared agenda. It will not be comfortable, and those leaders must be prepared to be at least temporarily unpopular with their colleagues, members, or constituents, as the case is argued. Crisis is all around us. Difficulties abound, and yet there is room for optimism based on the skills, intelligence, resourcefulness and achievement of those who work for and with the NHS. I spoke of tribes. The membership of this organisation represents one of our most important and successful tribes, the tribe of people who kept the NHS going this winter. Working together, we can surely succeed in preparing it for the future.
Now, it sounded to me as though there was something wrong with Dr. Cadigan's microphone there, so thanks to the stenographer, because I'm assuming you were all able to keep up if you couldn't hear. We'll see if we can sort that out now. And I think before we sort of leap into the whole sort of reconfiguration discussion, well, in one sense it is reconfiguration of a rather different type that you put in front of us, Andy Burnham. You're going to repeal the Health and Social Care Act. You're going to merge health and social care, and you're going to put it in the control of local authorities, but it is not top-down reorganisation.
Yes, that's right. Good summary. I'm glad you were listening. Well, absolutely, because I think this is where politicians have got themselves in a mess. And quite frankly, it's where Lansley got himself in a mess. They confuse service change with structural change. And the two things are very different. I think, as David was saying yesterday, one distracts from another. And I think, as all of the speakers we've just heard have eloquently put forward, it's service change that the system needs. So the bill, part 3, the market framework that the bill brings in, has to go. I mean, it just has to go. It just cannot accept it.
But hold on, so it has to go.
Yeah,
and we're talking, let's say you get in post-2015, it's been in place for 2 years, you are still going to repeal it. It's been in place for 2 years.
It can't stay. Because it can't stay.
And in the repealing of it, there will be a fuss, but that's just the price?
Well, just to answer it. It can't stay because it can't deliver what we're talking about. You know, Torbay, the famous pioneer of integration, is now saying that its famous system is under threat from the bill because it's having to contract out elements of its services, so it threatens its critical mass. So the organisations can be, the legislation that creates CCG's health and wellbeing bills can be carried forward in a repealing bill. But I'm absolutely clear, yes, that the market framework has to go because it's the wrong answer to the future, as I said in my speech.
Dr. David Bennett, the Chief Executive of Monitor, spoke at this conference yesterday, and he said it's no different than what already exists in European law. And so the argument is that you repeal it, you can remove it, and it's not going to make any difference because exactly the same rules will apply under European law.
But that's the problem, Sarah, isn't it? There's this kind of a mantra of the inexorability of the market, that you just have to accept it because it's coming. And you know, but I don't.
No, but the argument is here and it was here before.
No, because health has a designation under European law. And if it was exactly the same as what we left behind, why did we need a 300-page bill and the Section 75 regulations that came after it?
Presumably, as I understand it, the argument for why there's the significant change now isn't the existence of Section 75, at least as it was argued to me. It's that you now have a situation where you have CCGs doing the commissioning and you have effectively a market available, which is what opens up the market.
Well, yes, that's right, but that's the system that's been created. I think the white paper in its purest form envisaged a very open free-for-all, and it was brought back to a more recognisable planned system by some of the necessary modifications that were made as the bill struggled. But in its, you know, that essence is still there, and I think in the end it drives the system towards fragmentation, and that is not the answer to the future. You know, we're seeing
so in 2 years' time, paint us a picture of what will happen by the time there's an election and you're...
In 2 years' time, a bill comes through. I mean, I'm out early, don't forget.
No, but I mean, sorry, forgive me. What I meant was, what do you think will have happened by the time of the next election?
I think a lot more services will have been contracted out. I think hospitals will be in a more parlous state than they are now. I think social care will be getting very close to being overwhelmed, being in a very dangerous position. I think the pressure on hospitals won't have been relieved because I don't believe the government has had anything like the grip it needs or the foresight it needed to see this coming. You know, when they quote me in the House of Commons that I was irresponsible to say that I wouldn't give the NHS real terms increases, they never quote the second half of that sentence. And the second half said, because if the way you give the NHS increases is to ransack local government so that it can't provide decent care in the home, that problem ends up on the door of the NHS. It's a false economy, and they're not going to correct that. And that explains why hospitals are just under siege from all angles. So, yes, it'd be a very difficult inheritance, but I'm quite clear that the future lies in a single, the system is essentially one system. Let's take away the perverse disincentives where basically older people are left drifting towards hospital. Let's rethink this system and, as I say, give local government and the acute trust a positive future to grow into.
Okay, Jeremy rather politely referred to the unintended, beware the unintended consequences. I mean, in one sense, I don't even know if it's unintended, but if you are merging a system which is free at the point of use, as the health system is, and paid for nationally, with social care which is not, and paid for locally, I mean, surely the way to combine those, the complexities and the changes that would be required to effect a complete integration is a huge reorganisation.
Well, this is one of the major problems that we've got. And I'm not saying that it wasn't, we didn't address it either, but social care is the ultimate local lottery. So what you have all over the country is differential entitlement. But as councils are hitting this pressure, they are increasingly withdrawing what they provide to people with critical and substantial needs. And they do get social care provided free. And also there are universal services that are provided, such as reablement. So when somebody leaves hospital, there is a universal reablement service to help them get back on their feet. So what I'm saying is, you combine the budget and you make the best entitlement you can for people from that combined budget. And actually, there is, as Torbay has shown, and apologies, you know, I've already mentioned it twice, and I'll make sure it's the last mention of Torbay, but they have shown that if you go to a model that is based around the person, the family, it starts in the home, and you build out from there, genuinely, you can transfer resource from the acute sector to better services in the home. They have closed around 200 acute general medical beds in Torbay without any great, huge hoo-ha from the local public. Now, that's the kind of change that needs to happen evolutionary. And just the final point, I actually don't think I'm asking people to do. People know this. You know, they want to go in this direction. You know, it's not me coming along and saying something entirely new that nobody has heard before. They are just battling with the idea that these systems were created as separate. The council over here, the NHS over there, and they're trying to fight that tide. And I'm just saying now the time is now to embrace it, to make a more positive link between health and housing, health and planning, health and leisure, and refocus and tilt the system towards prevention.
Let's broaden this out to the sort of whole how you get to this point of redesigning, reconfiguring services. Is David Nicholson right? Yesterday he said, you'll never get a politician to recommend a closure. And he said it's up to us to do it. Is he right?
I think David's been a little unfair there because I put forward difficult reconfigurations, one in my own backyard in Greater Manchester, maternity and children's review, that caused a lot of difficulty. You may remember some of my colleagues who were ministers at the time pretty forcefully opposing it. So we put through difficult changes when we were in government. One of the last changes that I put through, working with David and the department, was the NHS London, Healthcare for London stroke reconfiguration, where stroke services were reduced from 12 sites to 8. And already lives are being saved as a result of that. So it's not fair to say that we just kind of said, oh, no, it's all too difficult. We didn't. We did some very difficult things.
But I want to broaden out, because Dr. Cadigan, I'm conscious that the stroke example comes up again and again, and in a way you can see why, and it's not an easy way, but you can see why it would result in redesign, because you've got the solution before, it's working for people. But you take something like what happened in Leeds, where for the benefit of the country, everybody says you've got to have fewer children's heart surgery units, but nobody wants it on their patch, or to have their patch closed.
Well, I think I started off my talk by talking about emotion and loyalty, and there is loyalty to institutions, and there are some some very big barriers to be overcome in these matters. I think the point that the report makes is that one really has to have the evidence. The evidence will persuade the clinicians for the most part, and again, clinicians are not immune from this loyalty and emotion. But if we have the evidence, then we have a way to go. And so stroke is a very good example. The other thing is the centralisation of services for angioplasty.
Okay, but I'm trying to get away because everybody throws stroke at me whenever I ask this question. But what about, let's use the example of children's heart surgery, where the evidence, different people will look at different bits of evidence. And so, what you're looking for is something that is a solution that is good for the country.
Okay. Well, that's a complex problem where the data is still, to a certain extent, disputed. And one of the problems recently was the data being analysed in new ways. One of the good things there is that the data is published and made available. And heart surgery has led the way in that. And I think public availability of the data is a very important point here. But there are other things going on in heart surgery. So there's the thing about viability of units in terms of the number of operations they do and the number of surgeons that they employ. So that there are other factors.
Just to jump in, Sarah, there, because I think it is a good example to tease out some of the difficulties here. I absolutely support the reduction in sites, and we put that forward as we set up the review as a government. But the NHS sometimes is a little cavalier on geography and travel times. I think often it sees the clinical case very clearly, but thinks a bit less than it should about how difficult it might be to travel if you've got a poorly child and 2 or 3 others who are at school. And I think geography and access needs sometimes to be more part of the equation. I looked at the site selection, and there was, yes, a unit in Newcastle with that review, but then the whole of the east of England, Leeds, taken out, Leicester, nothing right until London. So it's not surprising that people on the east of England would say, hang on, is this fair to us when there's one in Southampton, Bristol, Liverpool, Birmingham, where the west is very well connected? And I just think sometimes the NHS needs to be better at, yes, making difficult decisions, but understanding where ordinary people are and the difficulties they would have. Stephen
Dalton, from what you were saying, from the example of care in the community, whichever one hospital they pick, in this example, there's a hospital, or 3 hospitals that have to close. How do you get, remind us what happened in care in the community, in that, as you say, it was incredibly unpopular publicly, but it was done.
It was done, and it wasn't without its tragedies. It's not the case that I think one of the things problems that we have in terms of going forward is that, particularly in a post-Francis world, we have a situation where regulators feel the need to minimise risk and I think the whole system is seeking to somehow have a conversation that suggests to the public that we can minimise and eliminate risk, when in fact, if you look at the success of the major paradigm shift in mental health services, it was all about managing risk differently. If you want a risk-free mental health service, build a 1,500-bedded hospital, put everybody in it, and there won't be any problems. But that's the problem. If you actually want to make a change, we've got a collision at the moment of this kind of, post-Francis, post-mid-staff's arrangement, where I think we're making a promise to the public, which perhaps we won't be able to keep, because actually we need to manage things differently. We're going to have to manage
and it will be a paradigm shift.
And it will be a paradigm shift together. If not, I think we're going to live with a bust system.
Jeremy Taylor.
Yeah, mental health is both a powerful exemplar of what can be done, but also provides a warning, because one of the things that went wrong with care in the community was we ended up with not enough care in the community. So the system was very good at closing down institutions and less good at re-providing community-based services. And there's still a problem with the unavailability of community-based mental health services. So that is a very powerful lesson, which is why I think the report is right to quote Paul Burstow, where he says, if you haven't sorted out your primary community bit, then maybe you haven't passed the test. And just on the issue of evidence, so I think the NHS is very good at marshalling cost information and getting much better at marshalling clinical outcome evidence. Evidence from patients is still much more patchy and taken less seriously. The experience that people have of existing services is a critical part of the evidence base. And concerns about transport and access are absolutely key. You're quite right, Andy, and it's referenced in our report. And there are some case examples of where that's been done well by setting up a dedicated access forum with patients and local communities to look at the issues of if we're going to make people move further away to get their care, we've got to sort out their transport.
Okay, but just in terms of how these things happen, don't you have to effectively close the hospital to release the funds to create the care in the community now? I mean...
Well, I guess this, you know, it's not without its problems, because of course what happened with the transformation in mental health was that the political courage as well was around actually having double running costs. So you can't close the hospital overnight, so you have to create, and I think it's right that we didn't create enough community care. I think that was addressed later on, and you know, I wouldn't want to send out...
It's affording the change, though.
It's affording the change, and you've got to make the investment in change, because change costs lots of money. And I think that one of the things we have to be careful about is also promising the public that somehow this change will reduce in the way in which we manage the budget as well. It's about managing demand. It's about something that we can't do anything about. And it's the demographic changes, and it's issues like dementia, things that we have no control over, but we have to design the right response to what's going to happen to us.
Okay.
No, I agree very strongly with that. And I think there are examples, though, where services have been moved out of hospitals, Torbaya mentioned, without any huge kind of, you know, it can be done. And it's often the way it's done. And the NHS sometimes is not very good at marshalling its argument, the clinical argument. It kind of allows a forest fire to build up that then kind of will stand in the way of change. I think, to be honest, sometimes because of the kind of financial imperative or the kind of people's worry, they feel they have to make a quick argument and drive a proposal through. And often it just gets off on the wrong foot and then doesn't recover. And what I'm hoping to do is, if you were to move in the way I'm describing with a more integrated budget, where you could take a longer term view and, as I say, not have a big bang approach to reconfiguration, but do it progressively, working with the local partners, that in the end is the way to do it, to take people with you and actually be clearer with the public about why you're doing it and what you're offering them as a result. So you might say, for instance, you know, we are doing this so that we can provide one point of contact in your home, aids and adaptations in your home on the day you need them, occupational therapists when you need them, district nurses. You know, we never spell out clearly to the public what they're getting in return for the closure. And actually, no wonder they then start to get upset about the closure, because they just see something going.
Some questions. Microphone 1.
Thank you. Andrea Sutcliffe, I'm the Chief Executive of the Social Care Institute for Excellence. And I think there was a lot to welcome, really, Andy, from what you said, and the Twitter sphere is agreeing on this. Focus on the focus on the whole person, link of physical, mental and social care, promise of no top-down reorganisation, and the honest recognition that you don't have all the answers. But there are conundrums, and you've already been pressed on them. But I think from the floor, I'd like to press you again. You've kind of highlighted clearly that the market in health presents a barrier to integration. But from a social care perspective, a tremendous amount of the services are provided by the private sector and the third sector. And I think we've got to be positive about that. Integration is not just hospitals and local authorities. And secondly, I mean, big conundrum, Sarah's already asked you about it, but suggesting that shifting responsibility of provision to district general hospitals and the health service and commissioning to local authorities, I'm just worried that will inevitably mean another reorganisation and disruption. And we know that things work when relationships and trust are built up, and that takes time to do. And we need to make sure that we actually allow that time to happen.
Okay, they're fair questions, but some areas have gone in this direction without it being a structural reorganisation. I think that's the test, is it? Structural reorganisation means new organisations, upheaval, new jobs, people leaving jobs, joining new jobs. That's what that means, redundancies, consultants brought in. I'm saying to you very clearly that there will be a body here, the Health and Wellbeing Board. It's probably the best thing that came out of the Health and Social Care Act 2012. That entity becomes preeminent. That is the body that sets a population-wide commissioning strategy. And because the local authority is at the centre of it, it can link the health policy to the housing policy, to the planning policy, to the leisure policy, to the education policy. Until you make those linkages, I honestly don't think, how can you deliver a policy that is about the determinants of health as well as just treating ill health? And on your second point, on your other point, I'm not saying the NHS in a monopolistic way takes over everything. But what I am saying is it should become responsible for the coordination of care. Because at the moment, it's the coordination of those social care providers. At the moment, the hospital is dealing with problems outside of its control. The failure of organisations to provide decent care in the home means that it can't move people through the hospital, or too many people are coming in through the front door. So I'm saying if an organisation evolves into a home-to-hospital, physical, mental, social care provider that coordinates and works with other partners, builds a one-team approach, surely that is the way to go, to build a system that is about prevention and the whole person.
Forgive me, because we've only got a few minutes, so I'll ask everybody to be brief. Microphone 2 and then 3.
Thank you. Yeah, I'm Chris Butler. I'm Chief Executive of Leeds and York Partnership NHS Foundation Trust. Very much welcome the emphasis on mental health issues. Evidently more to do around physical health with people with mental health problems, combating stigma in the community and so on. Heard a lot this week about pressures in A&E, the Francis report and so on and so forth, but I've heard nothing at all this week about something else which has been happening in the system related to the systematic physical abuse of people with learning disabilities at Winterbourne View. And what I'd like to do is ask the panel about their views about the future of learning disability services as well as mental health services.
Okay, it's a very big question, and I think in the final moments of the conference we're probably not going to do it justice, but can I have just, perhaps do you want to start on this, just a very brief comment if you would.
Well, very briefly, clearly there are factors about Winterbourne View that we should learn lessons about future regulation over, about the nature of isolated units where there isn't sufficient focus, people being housed a long way away from home. It's all there, the evidence is all there as to what went wrong, and we need to learn from it, but we fail to learn sometimes.
Okay. Jeremy, did you want a quick word?
Just bad care can happen in some institutions, and we should be worried about isolated units. But bad care can also happen everywhere, and the campaign by MenCap, Death by Indifference, and the work that followed demonstrates that people with learning disabilities are quite often disadvantaged across the system. We should worry about that too. So we shouldn't just focus on institutions.
Okay, microphone 3.
Hi, this is directed at Andy Burnham. I, along with my colleagues, I'm a second-year nursing student at the University of York. You talked about being battered and bruised and demoralised, which we are before we're actually entering the NHS. We're here today as part of some work we did with NHS Change Day to improve patient care. And we want to ask you to pledge your support for the emerging frontline staff, because we're arranging an event between nurses, doctors and physiotherapists to improve the coordinated care that you're talking about. Okay. And we would like for you to attend to show your support for the next generation of frontline staff.
What's the date and time?
You're going to fill my diary.
That one's not set in stone yet, but...
I will. I'll see afterwards and see if I can...
Right, thank you.
Okay, very good use of the floor. Almost... Actually, no, it's not. It was a terrible use of the floor. Look, I'm well over time, and so I can't help wondering whether you regret that you didn't do what you're now saying you're going to do when you were. And at a time when there was money.
Yeah, I mean, that's a fair question. But I did try and reform social care, you might remember. Because I recognised that I thought social care was the big issue. To be honest, it's a personal thing. My grandmother went from this great city, went through the care system, and it was pretty, not in here actually, near where I live, and it was terrible, really. And my mum said to me, I remember, if you ever get into politics, you better do something about this. And those, you don't know, a Scouse mother, you never say no to her. And I, went into the department. I wanted to reform social care, but I came out of the department and I reflected on something very important. They in the department have social care policy like boxed off over there, and mental health policy is boxed off over there. And the NHS, the tanks of the NHS dominate everything, and they're all the things that the ministers hear about all of the time. And I came through having proposed a national care service because it was on a very social care track at the time, and just thought, actually, that isn't in the end the answer. The answer is, this is one person wants one set of services, one system to look after the physical, the mental, and the social. And social is prevention. So my thinking evolved when I started to think about the future of the DGH, the future of the local authority, the way everybody works together. And this policy is about trying to align those things. But rather than thinking about institutions and their kind of hierarchies, start with the person, start with the individual, build everything that they need around them in their home, and then let everybody work towards that. And so, yes, to answer the question honestly, there may be a bit of reorganization. There may be stuff that is like a kind of, there may be kind of changes to the way budgets work.
And instability.
But I think I have got offers coming in from all over the country saying, can we be a whole person care pilot?
Okay.
And that is a brilliant thing. And I think that says to you that this is a bit of change that most people out there want to embrace and get on with.
Andy Burnham, Stephen Dalton, Jeremy Taylor, Dr. Patrick Cadigan, thank you all very much. We're going to vacate and leave the stage for the final minute or two to Michael O'Higgins, the chairman of the NHS Confederation, who has the final word to close the conference. Thank you all very much.
Thank you, Sarah. I won't detain you for very long. I want to make 3 points before I go to the thank you bit. Firstly, I began on Wednesday by talking about leadership and culture, and that's been a theme throughout sort of the discussions at the conference, which I'm very pleased about that. Secondly, we've got widespread agreement from speakers here and politicians who are speakers, about the reconfiguration debate. The stuff that came out on Wednesday morning between the managers, the clinicians, and the patients was a really good example of how we need to work in partnership to deliver some of these things. What we're going to do over the next couple of years, but consistently, is get that narrative as the only game in town. So that even if politicians don't want to come to a consensus about what has to happen in health and social care, we're the only story in town, and they have to get on our bus. And as Mike said on Wednesday, we'll be setting out, before the manifestos come out, what needs to happen and how their manifestos should be judged against what we say. But thirdly, and picking up something David spoke about yesterday and that Jeremy mentioned, it's about engaging with the public. And I remember in a conversation a little while ago, somebody said, but that's a bit like politicians and elections. You only see them at election time. And the public could very rightly say in local areas that the only time they get engaged with about the health service, is when there's a closure coming. So no wonder they're suspicious. And if we're going to engage, you have to engage properly, not as a sham consultation. There's something I remember from my time as an academic, which goes something like, consultation is the process of taking account of the views of those whose views don't count. Because if they did count, they'd have been taken into account before the consultation began. That's not the sort of consultation that is going to deliver change. So I leave you with those 3 thoughts and look forward to seeing you back up north next year for the conference. I'd like to thank our event partners, Allocate Software and BT, for the support. I would like to thank the Confed staff who helped make this happen, and the venue staff who've been so good in looking after us. And I'd like to thank you for your time, your attention, your engagement, and the commitment you have to delivering health and social care to people. Thank you.